Dr. Farshid Sam Rahbar is the founder and medical director of Los Angeles Integrative Gastroenterology and Nutrition. As an acclaimed gastroenterologist, Dr. Rahbar combines his experience, knowledge, and highly advanced techniques with the art of functional medicine, providing patients with all-encompassing and comprehensive approach to GI health. Please give a warm welcome to Dr. Rahbar.
Good morning again. I am very excited to be among this distinguished faculty, as well as, I don't want to say addicted, but interested SIBO audience, both present here and also on a distance watching us. Okay. Good morning to all. I'm very excited to share with you our clinical experience in the practice over the last several years, as how SIBO has evolved for us in understanding the meaning of it when we see it and what we do with it. So perhaps this will expand your area of knowledge in this area. Okay. The title I chose was SIBO and Related Microbiomes as Biological Markers of Systemic Illness. And this is probably a term you have not heard before, and it's not a concept you might have come across frequently, but you know, based on what we learned, I felt this would be appropriate at this time to present. That is my name, and then these are the people I acknowledge. Dr. Taj Karimi, a PhD microbiologist and Doctor of Veterinary Medicine, and Michael Erdman, a physician from England, who helped me to put these slide sets together. Okay. The goal of the presentation is to create a broader mindset of SIBO matters, pattern recognition in SIBO clinical scenarios, which means that we will be better clinicians, and understanding the interrelation of different microbiomes and some practical concepts that I would use based on the case examples. Okay. Our source of knowledge comes from literature, from networking, and from our experience, and also an upcoming publication which we have put together to publish, and it has been submitted for publication, not yet approved by the editor, but we will publish somewhere, and I think it's going to be very, very eye-opener, if you will. Okay. The disclaimers are important. One thing is not here, that there are two spelling mistakes in the slides. If you didn't pick it up, I'll point it out. Okay. Okay. This information is based on observation and evidence collected through the practice, but it is not necessarily peer-reviewed. When we looked for evidence of literature, we noticed that there was suboptimal amount of literature to support what we were seeing, and that prompted us to actually see if we can publish what we have learned. We believe the material that I'm presenting has clinical relevance, and I'm hoping that at least it will create some sort of ignite in the academic community to take this further for research. The question that I was asked myself is, when you see somebody with SIBO coming in, what is your level of confidence that the patient will respond to your treatment? And I've heard a variety of responses. Okay. I've heard as much as 90%. I've heard as much as predicting California earthquake, or maybe somewhere in between. Okay. The reality is that I do not have 100% confidence that we're going to be able to basically correct everybody's SIBO. Okay. And then those have reasons, and that's why we need to look and see what the reasons are that the patient is not necessarily responding to the treatments. Okay. Let's dismantle the subject. SIBO, a form of distorted microbiome that communicates with host and produces symptoms. Related microbiomes. This may include the formation or persistence of SIBO. They may contribute to formation or persistence of SIBO, and that would be sinus cavities, oral cavities, nasopharyngeal area, and gallbladder. At least these are the common ones that they communicate with the gut microbiome. Biological marker, okay, like fever is a biological marker. If somebody has a fever, you can say, okay, what's the cause of that? So you think about layers, behind that. So when you see SIBO, you may have to look at it as a biological marker. The need for investigating further. Consideration that SIBO treatment alone may not achieve improved health outcomes, regardless of whether the SIBO is eradicated or not. There may be lack of predictable or sustained response to SIBO treatment. And those of you who have treated SIBO enough number of times, you probably will relate to this type of comments. Systemic illness, the term incorporates more than disease, as it relates to a constellation of symptoms and multiple physiological derangements and more. Now, condition that predispose to SIBO, and I can tell you on the right-hand side in the black, you have classical one that we got off the textbooks, okay? And interestingly, in our practice, at least, common community practice, not a university hospital practice, we don't see too much of scleroderma or intestinal, diverticulosis and so forth. There may be some adhesions issues for people who have had inflammatory conditions of the abdomen or surgeries, but putting that aside, the right-hand side, I find it rather unusual to see nowadays based on what is classical in the textbooks. On the left one, things that are less talked about, achlorhydria or hypochlorhydria, motor abnormalities, alcoholism, and disorders of enteric nervous system. These are the things that we come across more nowadays. And also the underlying systemic illness. Again, the term that I want to come back to it to see that there is more than just a disease process. There's a constellation of physiological derangements when you see a SIBO that does not respond properly to the treatment. So the gas content of healthy subjects, already familiar with this, hydrogen, CO2, and methane. And then you have hydrogen sulfide that is being discussed more now. You have some nitrogen and oxygen, and there may be some other smaller gases there, which I put down at the bottom of the slide. Current classification of SIBO, as you all know, hydrogen producer, methane producer, hydrogen and methane producer, and hydrogen sulfide producer. There may be some other categories coming, but this is what we know based on the current gas patterns, okay? Now, when we dismantle the subject, we want to be able to understand what is in that systemic illness. And to be able to delve deeper into causes beyond SIBO, one must become an onion thinker. I hope the term creates a little bit of a curiosity. But you think of this as a systemic illness that has multiple layers. SIBO pattern recognition, okay? Can we propose something not only based on the gases, but based on gas pattern as well as clinical response? Now, if you look at the clinical response and the gas patterns, we came up with this. We came up with 10 patterns that is easy to kind of remember. And I had to give these some names to kind of remember what is type 1, type 2, because I just made this up. Okay. The type 1 is the easy rider. Okay. And those of you who watched the movie from some years ago, it's an easy name to remember. And I'm going to go over the definition. Type 2, the persister, the relapser, the megagas, the megameth, the blend, the paradox, the incongruent, the silent abdomen, the flat line, H2S, which has a new name, the new kid on the block, because I understand that this H2S is now being produced and is not always flat. Okay, let's look at these patterns so we see if you can relate to it if you have been treating SIBO. Hydrogen, easy rider, hydrogen and methane producer that responds to treatment, stays in remission with some lifestyle and diet modifications, and shows benefit from nocturnal motility agent, and the vinculin antibody and the CDTB may be positive or may not be positive, but you had a good response. This is your good responder, happy patient, happy doctor. Type 2, the persister, hydrogen and methane producer that does not respond to treatment in a predictable manner. Breath test continues to be abnormal, and that's why we call it the persister. Okay. The relapser, hydrogen and methane producer that responds to treatment, breath test improves significantly or normalizes, but there's a tendency for frequent relapses. The megagas, this is the hydrogen and or methane producer that is identified with very high levels of hydrogen and methane and tends to be either a relapser or persister. The megameth, okay, don't think about the movie Breaking Bad, okay, very high methane producer could also be a persister relapser, generally hard to treat, may have little symptoms and no constipation. Query risk factors for this condition, particularly elevation of TMAO, trimethyl amine nitrogen oxide. If diarrhea is present, suspect presence of parasites. The blend, hydrogen and methane producer that could be mild, moderate, or severe, also shows evidence of clinical scenario of yeast, and most of you have practiced and read the books. You realize that the clinical picture of yeast is something that one has to judge clinically most of the time. Treatment usually requires concurrent or sequential antifungal and antibacterial protocols. Okay. The paradox, hydrogen or methane producer that after treatment, patient feels worse. Breath test may or may not look more abnormal. Suspect another cause of fermentation, and that generally would be the yeast clinical scenario. Okay. The incongruent hydrogen or methane producer responds to the treatment. You have complete or near complete normalization of the breath test. However, no or partial clinical improvement. In other words, there is a lack of congruency between normalization of the test and correction of SIBO or other symptoms. The silent abdomen, okay. Hydrogen and methane producer. Patient has received multiple courses of treatments for SIBO. SIBO more likely than not is corrected already. Patient complains of persistent bloating. However, flatulence is not a complaint. Patient history and physical exam suggest lack of borborygmy or even normal bowel sounds. Suspect autonomic dysfunction, dysautonomia, and problems with enteric nervous system. This is your persistent bloater. The flat line, or the new kid on the block, no hydrogen methane produced, likely presence of hydrogen sulfide. Research in this area is evolving. So we're going to get to the next slide, and honestly, I think this is probably the most important take-home message I like to leave it with you. Type 2 to 9 is when you have to be concerned. Pattern 2 to 9 have a high likelihood of being associated with an underlying systemic illness. Okay, so now that onion thinking needs to come into place. What's going on beyond this? Okay, keep hitting the SIBO, and it doesn't go away. It may not get you anywhere until you explore further. Okay. Thought-provoking case examples. Okay, I give you the cases. You can think about it, and then somewhere through the slide says we will go over the answers. Okay. Case 1, clinically 69-year-old male, clinically presented with gastroenteritis, responded to 7 days of ciprofloxacin, felt good. 3 months later, patient returned. New symptom developed: gas, bloating, abdominal pain, flatulence. The gas pattern, you can see a very high number of hydrogen at some level of methane. So this would be a mega gas type of pattern, okay? And we treated the patient, no change, okay? Still the numbers are very high. It's basically a persister now, okay? On the blood test, globulin level shows 4.7, total protein slightly elevated, and there's a little bit of anemia going on. What is your next step? Okay, you can think about it, and we'll come back in a few minutes. Okay, case 2, 25-year-old female, no GI symptoms, loss of eyelashes from one eye, mild facial redness, high level of stress, irregular and slightly heavy periods. The patient sent me this picture with her eyelashes dropping on her face. Okay. You do a SIBO test, you think about immune provocation, and the SIBO test is abnormal. The methane reaches abnormality, and it's probably moderately abnormal breath test. We did additional work. There was some urine fungal markers, and glyphosate was a little bit present, but this is really not the worst one. Almost I have not had anybody who did not have glyphosate in their urine, but this number is not very impressive. And then say, oh, you know, transglutaminase antibody is positive. It's probably celiac or showing some gluten sensitivity as a secondary phenomenon to leaky gut associated with SIBO. And there's also iron deficiency, which can go with SIBO or heavy periods or things like that. So I have several areas that I can target. And autoimmunity is turned on. The ANA is positive. So the patient was treated with Xifax and iron infusion and nystatin. I definitely would not give iron orally because iron is loved by the bacteria, and that's why we have lactoferrin there. So this she was given iron infusion. Some clinical improvement was noted, but shedding of the eyelashes did not stop. What is your next step? Okay, let's think about it, and we'll come back in a few minutes and see where we are with this. Okay. Case 3, 27-year-old female from New York City, abdominal pain, a lot of bloating, weight gain, fluid retention, musculoskeletal pain, low energy. SIBO test is, mild to moderately abnormal. And this patient, she couldn't really eat anything. We put her directly right on elemental diet. And you can see the breath test is actually normalized. Okay, she lost weight, the bloating was reduced. But when you listen to the story, she is not fully recovered, systemic illness, okay? Patients still have some ongoing symptoms. We're not done. My breath test is normal, so there's something else going on. What's your next step? Okay, microbiome and microbiota. This was already mentioned. Microbiome relates to genetic pool. Microbiota is all microbes that inhabit the gut. Now, this is not just limited to the gut. We have urogenital, oral, lung, skin, sinus cavities, and gallbladder. You can call it gallbiome. I found it in one of the references that I was looking. And it's interesting that this is the article by Gerald Mullins, and they have a reference for that. Cholecystectomy actually reduces the risk of having SIBO. So my interpretation would be that if the gallbladder microbiome is contaminated for one reason or another, every time there's a gush of bile going out, it basically is going to contaminate it, and I'm going to be dealing with a persistent SIBO problem. Maybe it's my gallbladder. Maybe that microbiome is communicating and it's keeping the gut contaminated in that area, because if you conclude from this cholecystectomy reduces the risk of SIBO, then that's the way I would extrapolate from this information. Okay. Interplay of microbiomes with host and each other. Okay. Microbes and their host exert pressure on one another. One microbiome ecosystem can affect another one. Examples: gut microbiome can affect the vaginal flora. Nose and sinus microbiome can affect gut and cause gut dysbiosis. Hypochlorhydria may be a contributing factor. We found a lot of our patients who had SIBO-related issues. There were patterns from 2 to 9. Marcons were quite common in SIBO patients. MARCON standing for multiple antibiotic resistant coagulase negative staph. Dr. Shoemaker, who has written a lot about this, but it was interesting to us because we started to culture the nose of the patients, and even though it was a GI practice, we somehow had to learn how to do it, and we do a good job in culturing the nose, and we found that a lot of our patients had MARCONs present in the nose, which made the ENT department become a source for us to target in cases that we have difficulty treating the SIBO. Okay. A stool PCR technology acts as a representative assessment of intestinal microbiota. This is a rough approximation of the many microbial niches in the GI system. You're sampling the stool, trying to get a snapshot of the microbiome of the gut. I mean, does that represent the whole thing? Microbiota of the intestinal lumen is picked up by this, but more so of the colon. Microbiota at the biofilm level, which you never hear about it, but it is in the literature, next to the mucosa, is not well evaluated by this technology. We really don't know much about the microbiome. This is an area that hopefully in our lifetime we will learn more about it. This is the healthy adult gut microbiome based on the PCR technology, and you have the Bacteroidetes, the Firmicutes, then you have the Actinobacteria, Proteobacteria, Verruco microbiota, and the methanogenic bacteria, archaea, Fusobacteria, eukaryocytes, and bacteriophages. And again, I put that here because I want you to see, based on the article that was published in New England Journal of Medicine, that it says which one are the common ones and which one you have a smaller population. Okay. It's interesting, not much is mentioned about phagium, the colony of the bacteriophages. The bacteriophages are basically viruses that they target the bacteria and then keep them in shape and in a reasonable number. They eat them up. And I think this could be a very exciting area in the future to have a specific bacteriophages for a specific bacteria that you wish to target. Okay. Concepts. Okay. These are the concepts we learned. This is your pearl, clinical pearls that you may consider in your practice. Concept 1, the blind spot. Our observations: low-grade chronic sinusitis, bacterial or fungal, may contribute to persistence or recurrent gut dysbiosis. Hypothesis: low-grade sinus inflammation and postnasal discharge may find their access to the upper GI system, especially if associated with hypochlorhydria. Therefore, the sinus cavity's microbiome may have an intricate relationship with gut microbiome and may affect each other. I believe we also found one reference, and we put it there. Okay, clinical implications of the blind spot concept in patients presenting with digestive symptoms, particularly abdominal bloating. Providers should inquire about sinus-related symptoms, as subtle as it could be. I don't have enough time to go over some of the examples we have seen, but this could be very, very deceiving. Providers should consider nasal cultures of both nasal passages. In abnormal cases, referral to an ENT specialist to rule out anatomical abnormality may be indicated. Example 1 of the blind spot: SIBO, mycotoxins, and vector-borne illness. The title will tell you the layers of the onion. 35-year-old male, GI symptoms: excessive burping, flatulence, abdominal distension. Non-GI symptom: brain fog, peripheral neuropathy, sweet cravings, postnasal drip. The patient already came on 2 natural herbal products. I think he was on FC-Cidon and Dysbiocide, that if he did not take them, he would feel very bad. Okay. The breath test was done on this herbal protocol. We did not have the courage to stop it. As you can see, it is abnormal. And the nasal culture shows MARCONs positive, but it also shows penicillium, moderate growth, and as you know, that is a yeast. We did a stool analysis. You can see that even though the laboratory put this in under normal flora, There's Candida parapsilosis there. And if you read about this carefully, you can notice this is actually an opportunistic fungi. You see it in patients with chemotherapy, transplant. What is it doing in a young male walking to the office? The Klebsiella pneumoniae, something you think about pneumonia. What is it doing in the stool? So that would be a marker of the dysbiosis. And I must say that I personally would not target that. I know some people say, well, let's give antibiotics to kill this thing here. I think this is just a marker telling you something is wrong in upstream. We did a Heidelberg test in this patient, and his acidification was normal, but he had too many zigzag fluctuations in the pH, suggesting that he has bile reflux and pyloric insufficiency, which is an interesting concept. We're going to talk about it more. That means that the bile is backing up into the stomach, and it may add to his eructation and the burping problem. We looked at mycotoxins, all 4 of them, ochratoxin, aflatoxin, trichotillins, and gliotoxins. They were all positive. And look at the gliotoxin. This has a lot of neurological, preference, if you will, and it was 18 times above normal. And we checked him for tick-borne diseases, and he had Borrelia relapsing fever group blood IgM positive. It's almost like suggests it's an active infection. How many more layers we need to look? This is a multisystemic problem. The SIBO is just a tip of the iceberg. You can treat the SIBO. It won't get you anywhere unless you address the immune system sitting behind it. Take-home message, addressing SIBO alone would not have been sufficient to improve this patient's overall health and sense of well-being. His treatment approach required ENT referral, nasal treatments, examining home and work environment for mold exposure, and implementing a detoxification program and more. Concept 2, the downstream problem. Our observations. The presence of bile in the stomach is not normal and nearly always implies presence of a small bowel dysbiosis. There is very little written in classical textbooks. There's still, if you go look at some of the classical textbooks, they're still talking about doing gastric bypass to divert the bile. Think about small bowel dysbiosis, particularly proximal dysbiosis, something that was well emphasized last year by Dr. McCullum, that there's something called proximal SIBO, and it may be too high to get picked up easily. SIBO, SIFO, and parasites. All of these can produce a contaminated gut environment and give you a picture like this. We have examples of all of these things, and that's why we put it here. I call it downstream problem. Downstream problem hypothesis: a dirty gut environment leads to reverse duodenal peristalsis and regurgitation of bile into the stomach. Such phenomenon may lead to symptoms similar to hypochlorhydria without the latter truly being present. Mixing bile and stomach acid may cause maldigestion, especially in breakdown of protein. And the picture, basically, we put it there for you to relate to the concept. Example of the downstream problem: bile reflux and methane SIBO. 40-year-old female, indigestion, occasional diarrhea, irregular bowel movements, abdominal distension, flatulence, malaise, fatigue, dyspepsia, and nausea. History of H. pylori and Giardia, both of them were treated. Very high level of methane. This is a megameth. We did a Heidelberg test, and you can see again the acidification is normal. The patient reaches a low number in a reasonable time, but look at all the zigzag appearance that is going on. I'm not sure how well you can see, but hopefully you can get the message from this. Again, this is consistent with the bile reflux. Additional workup we did in this patient: bile reflux and methane SIBO. Again, in the stool, Rhodotrola mucilaginosa, plus Dianthemeba fragilis, and many yeast. This is the multi-level contaminated gut environment, and it's probably chronic. You look at the SIGA, it's so low that is allow the persistence of this type of scenario in the gut. Okay. This is the same patient. The next day, she came for endoscopy. Look at the amount of bile in the stomach. Case 3, downstream problem, parasite in the duodenum and minimal SIBO. Over 3 years of upper GI symptoms, was evaluated at major institutions. No clear cause for epigastric pain. A little bit of a SIBO. You can see the methane, and the hydrogen almost meet the SIBO 2016 consensus criteria. So is this the cause of the problem? Okay. Endoscopic findings, large amount of bile stained fluid in the stomach. Pyloric channel was patent. Biopsy showed foveolar hyperplasia and gastritis. Now, interesting, if you do a search, foveolar hyperplasia is commonly seen in the setting of bile gastritis and is not completely a benign scenario. This scenario is commonly seen in the presence of bile in the stomach. So in this case, we actually aspirated some juice from the duodenum to make sure we're not missing anything there. And we sent this for PCR. This was something I just came up with the idea. And Trichuris trichura, whipworm, showed up there. Okay, so I have a little SIBO and a parasite floating around in a young female with 3 years of symptoms, at least at 2 major university institutions. No clear answer. Whipworm was detected. She was treated, and within about, I would say, a month or so, she was about 30–40% better. But obviously, the treatment had multiple levels to hit targets to be able to see how you can achieve. Take-home message on bile gastritis. Providers ought to communicate with their consultant GI physicians. Ask for photographs of the stomach juice immediately upon entrance of the scope into the stomach before the juice is suctioned. Many physicians think this is normal. It is not normal. If you investigate, you're going to find something. Upon observation of bile in the stomach, providers should thoroughly investigate a variety of gut infections. Treating the pathology and restoring the physiology may correct the bile reflux into the stomach. Okay. Concept 3, stealth infections. Definition of stealth: having the ability to prevent being detected. Having the ability to prevent being detected. In medical sense, the organism is essentially undetectable or uncontrolled by the immune system. The organism can invite or coexist with other organisms and allow them to proliferate and affect bodily functions. Stealth infections, a common term that is used by holistic practitioners who deal with chronic illness, yet there is no such definition in classical textbooks. Stealth infections are commonly bacterial. However, they could be viral, parasitic, mycobacterial, or fungal. Okay. Tick and vector-borne illnesses are among these here. They're difficult to diagnose. There's no perfect single test. Some physicians may not believe in the concept, and this has clearly been shown that there is some resistance in accepting some of this scenario. Okay. Hopefully, by presenting cases and data, we can change that approach. Stealth infections could be acute, subacute, or carrier state. Acute or subacute or carrier states are well accepted in the literature. Yet the word stealth infection remains controversial. Good clinical judgment and pattern recognition is required. Pattern recognition means we become a better clinician. Okay, stealth infections, multi-infections can coexist. The presence of one infection keeps the immune system occupied, allowing other infections to possibly be more active. Stealth infections, subtitles, detoxification is commonly, the subtleties. Okay. Detoxification is commonly impaired. MTHFR mutations commonly exist. I personally stopped ordering the MTFHR because more than half of the patients we ordered, they came back showing good amount of mutation there. So it really wasn't changing our approach. IgM may be intermittently positive, further suggesting reactivation. IgG may show high titers, yet IgM may not be negative. That's where one of the errors is. Yet IgM may not be negative. This is very interesting. You don't hear this much in immunology when there's a discussion of IgM and IgG both being positive concurrently. You also don't hear if you have an IgG, you will have a PCR for virus being positive. I have turned to be very humble to think that these are possible, and the immunological behavior is not exactly according to the textbooks. I'll show you some examples. Again, IgG may be positive, but you may also see IgM being positive. Stealth infections, subtleties continued. PCR may be positive, revealing chronic microbial exposure in circulation. Acquired hypogammaglobulinemia may be present, hence serology may be negative and PCR being positive. Deficiencies of IgG subclasses 1 to 4 are quite common. Example of that is what they call latent borreliosis or latent Lyme, or the term chronic Lyme, which does not have an ICD-10 diagnosis, so is not necessarily recognized as a term in the medical literature. It is commonly used by physicians who do treat patients with chronic Lyme. The stealth infection, the host may be doing a good job in controlling multi-layer infections, yet this control comes with a price. Feeling chronically unwell, digestive symptoms are common. Hence, the patients may come to a gastroenterologist primarily with GI manifestations. On the stealth infections, when multiple infections are present, one may be the major player. And in treating one infection, another one may become manifested. Stealth infections, clinically, patients present with chronic illness. Okay, I'm not going to read all these things. Almost every system you can imagine may be involved. Immune dysregulation, cognitive dysfunction, chronic pains, neurologic symptoms, positive autoimmune markers. Okay. Now here are some of the examples of the bugs. If you start to look for them, you may see from HHV6, EBV, CMV, chlamydia, brucellosis, mycoplasma, parvovirus 19, rickettsial infection, Borrelia burgdorferi, and other Borrelia, including the relapsing fever group, and what we call the Lyme co-infections, Babesia, Bartonella, Anaplasma, and Ehrlichia. Manifestations of possible infections could be everything: rash, diarrhea, bad PMS, nail fungus, autoimmune disease. Please be kind enough to read through the list. For the sake of time, I'll avoid that. But please pay attention to atypical GERD and reflux-related symptoms. We're going to come back to that. This is from our experience. We looked at a number of patients. We went back and see whatever the top 10 symptoms came. And you have bloating, constipation, irregular bowel movements, abdominal pain. Okay. And it's all about dealing with the immune system and the allostatic load. This case 4, this was a case of Lyme disease patient that was referred to me. The patient was not responding to the Lyme treatment. She had these worms, like structures, they're really manifestations of a yeast problem that they present this with. These are not real worms, these are rope worms. SIBO test was abnormal, okay. And all therapeutic methods failed in this case, okay. White cell count was low, lead level was high. So, okay, maybe I found something. I'm going to treat the heavy metals and get rid of it. But I did not end up there. And in this case, multiple co-infections were positive. Herpes virus 6, IgG, was positive. But look at this, PCR positive. IgG positive, but PCR for herpes virus 6 positive. This was repeated. You can see the quantitative mark was very high. And the urine test shows presence of Bartonella bacilliformis, a type of Bartonella that does not readily have an antibody testing in US. This was picked up on the urine test. Patient failed antiviral treatment for the herpes virus given by an infectious disease physician. I sent the patient to a Lyme physician. She was treated. You can see the complements were low. She was treated with Invans with 6 to 8 weeks of IV antibiotics, and she fully recovered, okay, even though the virus was still floating around. Babesia is a very common problem in US. I'm going to go through this very quickly. And right now, if you want to donate blood, you would need to give a blood for Babesia, but they check for Babesia microti. They do not check for Babesia duncani, which is very common in West Coast. In Canada, they have already published that Babesia duncani is across their country. Take-home message, vector-borne illness is among the stealth infections. And if you see SIBOs from 2 to 9, that should prompt you to further investigation. Okay. High methane, these are the causes you would need to think about. Vector-borne illness, mycotoxins, TMAO, immune dysregulation, high glyphosate, and Paneth cells. Okay. Paneth cells are at the bottom of the crypt, and they're the guardians of the stem cells. They produce alpha defensins, that they are peptides that they will work like a bullet into the cell wall of the bacteria. So this is the local immunity of the gut, and I think this is very, very important. This is the forgotten cells. They do not talk about it. I think this is crucial in keeping the integrity of the small bowel, and that's why preventing recurrence of the SIBO. Okay. A little bit more on the Paneth cells. Okay. Now, how do we support the Paneth cells? And when I did some research, I found out triterpenoids, herbal saponins, okay, enhance beneficial bacteria, decrease sulfate-reducing bacteria, modulate the inflammatory intestinal response, and exert cancer prevention. We use Gynomesta pentophyllum quite frequently in the practice. We combine it with BPC, which was well discussed yesterday, is one of the best combinations you can use for the leaky gut. This is herbal, is very, very cheap. I think it's very safe, and it definitely is an adaptogen, but they don't talk about the beneficial effects on inflammation. You combine this with another peptide such as BPC, you will augment your benefits. Okay. Gynomesta pentophyllum saponins attenuate inflammation in vitro and in vivo by inhibition of the NF-kappa B. This to me is very valuable information. One of the concepts I had presented before, you see high methane, think of tick-borne diseases and Lyme. I already gave you examples, okay. TMAO, I have to go through this very quickly. Trimethylamine is generated by the gut bacteria and metabolized from choline and lecithin and L-carnitine. Then through the liver, this enzyme FMO3 converts the TMA to TMAO, which is the oxidized form. This is from the CDC website, so you can look at the mechanism of the conversion, but TMA, you can see choline basically turns to TMA, TMA to TMAO. Is not that simple. We looked at this archaeobacteria, proposed therapeutic use of archaea to prevent trimethylamine and cardiovascular disease. You mean I'm going to use archaea and methane production as a measure to reduce TMA to basically keep myself healthier, okay? So is it possible that the methane production is actually a mechanism that the body is using to keep itself less toxic, if you will? I don't know the answer to the question. You need to read the literature, but it's something to think about it. Conversion of choline methyl groups through trimethylamine into methane in rumen. Okay, TMA can turn into methane. So when we have high methane, is it possible that my egg yolks, okay, are basically becoming a substrate for conversion into the methane? That's why we asked every patient with high methane, the megameth, do you eat eggs? Okay, most of them are low carbohydrate. 90% of the anecdotals that I asked people, they said yes. Please ask your patient if they eat egg yolks, because that may be contributing to this. Utilization of trimethylamine and N-methyl compounds for growth and methane formation by another form of archaea. So there's more literature on this. For the sake of time, I need to go through them quickly. But I want to leave you with this here. Look at this. The TMA, it has a CH3, and methane is CH4. You only need one hydrogen added to each of those CH3s, and you're going to get 3 of the CH4 generated. So it's very easy for this to happen. You can check a TMAO in the blood through Quest Lab, and we have an example of a case here. This guy came with bad breath, stomach bloating, methane through the roof. This is a megameth. Nothing works on the treatment. Glyphosate was like this, and there were some bacterial organic acids showing up, so obviously he was very dysbiotic. Now we asked him to basically eat eggs. He said he's eating a lot of eggs and meat and shellfish. All of these can increase the TMAO, and his number was elevated. I said, I have a high methane, I have a high TMAO, maybe these two are related. And we asked him to eliminate the egg yolk, and this is his repeat test without treatment. Okay, there was no treatment. The numbers came down, I don't know, by 20%. And it's not so bad. My treatment didn't do this much. By just eliminating those dietary elements, his numbers came down. I think this is an area that needs to be explored further, and hopefully it would be a good reason to explore. Okay, on the repeat testing, his TMAO also dropped. Okay, high methane. This is another patient from New Jersey. Again, a lot of megameth. Okay, nothing getting better. You can see, and glyphosate showing up in some number. The liver tests were a little bit elevated. And here you can see this patient had Babesia positive by fish technique. That means that they were able to see it in the blood. Okay. Take-home message, high methane, evaluate immune dysregulation, mycotoxins, and immune and stealth infections. On those cases we discussed earlier, okay, the first case, the 69-year-old with gastroenteritis, globulin level was elevated. We did additional, which is the total protein 8.8, gamma globulin elevated, kappa and lambda. I ordered light chains to be checked. This patient had multiple myeloma confirmed. Okay, one episode of SIBO did not respond. I could have easily ignored a globulin of 4.7. Upper normal was 4.5. This patient had multiple myeloma. He's currently under treatment. Thought-provoking cases. This case you remember. Hydrogen and methane producer, eyelashes lost, which is very disturbing for a young person. Receive antifungals. Okay, Babesia fish positive. Look at the numbers. Babesia duncani IgM is very elevated. Upper normal is 40. Okay, this is 320. Babesia fish technique positive. Okay, the case with the bloating and fatigue that was 50% better. Okay. This patient lived in New York and has positive Lyme markers, meeting criteria both by the lab and Center for Disease Control. This was a case of Lyme disease. I had to refer to somebody in New York to handle her. Okay. Interesting cases. This is a case of hypochlorhydria and Bartonella. We speculated this is probably a neuropathy associated. You can see the, Steve, you can probably relate to this. Is a long, non-acidification. These are the Bartonella on her skin. We suspected this may be the case. And you can see Bartonella, QuinTron, and Henseley. They were reactive by a special lab. Difficult cases, again, this is a feeding difficulty, dysphagia, again, turned out to be Babesia. Look at this, hypochlorhydria and growth of yeast in the stool, multiple issues going on at the same time. The CD count is low, the TGF-beta, which is a marker for innate immunity, was elevated. Okay, Babesia duncani, marker positive, and swallowing difficulties. This is a different case, this time with eosinophilic esophagitis, dysphagia, malaise, postprandial mental fog. You can see hydrogen producer, very elevated, eosinophils elevated, Ig elevated, and TGF-beta elevated. So you can say, oh, you know what, I probably have eosinophilic esophagitis. But look at this. On the endoscopy, he showed evidence of gastroparesis. Okay, so I have now a component of neuropathy associated with this, and also has eosinophilic esophagitis. I have multiple layer problems. Okay, my immune system is turned from Th1 to Th2. I have eosinophilic esophagitis, which is usually associated with food sensitivities, and I have gastroparesis. I have SIBO. Hey, what's going on here? Okay, and here's what came back. Okay. Lyme markers positive. You can see on the CDC criteria positive. This is Western blot. Babesia duncani positive. Also Bartonella henselae, IgM positive, commonly associated with neuropathy, autonomic neuropathy. Okay. Multiple layers. Cyclic vomiting syndrome and Babesia. This is another case. And this is somebody, again, a similar case continuing. You can see anti-gliadin being positive. Again, Babesia microti, IgM 320, very, very elevated. Okay. Next case is falling episodes and tick-borne illness. This is the patient did not come to the office. The spouse brought the patient with a video and pictures. Okay. The breath test not so abnormal, but gas, bloating, abdominal pain, so just have a SIBO problem. The breath test is negative. And eventually we end up doing an endoscopy, same thing. Okay, so even though the breath test is negative, I am suspecting that the patient may have proximal gut dysbiosis. Okay. You can see immune markers are suppressed. CD57 is low. TGF-beta is elevated. Look at the complement A is elevated, C4A. And this is a marker that goes up in Lyme and mycotoxins. And testosterone very low, DHEA low, cortisol low, IGF-1 low, LH low. This patient has panhypopituitarism. So suddenly, not bad for a GI doctor, huh? Okay. So picked up all of this. Okay. We did send the patient to UCLA, doctor they put the patient in the hospital. They did a growth hormone stimulation test, and he mounted nothing. You can see all the numbers are the same. His growth hormone did not go up, so he had growth hormone deficiency. You know, his cortisol was low, his testosterone was low. So we treated him with all these hormones, and you know, he's going to probably perk up. He has growth hormone deficiency. It was hard to get it through the insurance, but it did. And look at this, Babesia duncani positive, relapsing fever group, Western blot, IgM positive. He was from Michigan, and he did a lot of camping out. We had to add that history. Okay. Borderline SIBO and unrelenting symptoms. Again, you can see multiple, there are other examples of this. In this particular case, the glyphosate was very high. So it's another case of gut dysbiosis. One case of vaginal symptoms and SIBO. Look at this one here. Methane is very high. Recurrent vaginal dysbiosis, bacteriovaginosis, a lot of discharge. Okay. And because of the high methane, you know, I checked. I said, look, you have immune dysregulation. Let me check that. This is the principle I learned from myself. Look at this here, okay. CDC criteria positive for Lyme, but look at this. Serum plasmid positive, whole blood plasmid positive. This patient has floating Borrelia in the blood, okay. And then here you can see Babesia fishes positive. This is our retrospective study where vector-borne illness associated with small bowel bacterial overgrowth, the significance link between digestive and non-digestive symptoms. Interestingly, the SIBO was very prevalent in our patients with tick-borne diseases, but still statistically was very similar to the patients who did not have these illnesses. So the odds ratio was 0.99. You need something more than 1 to make it statistically significant. So it didn't reach a statistical significance. But I can say that half of those patients who had vector-borne illness, a lot of them, they had SIBO. Okay, so if I see, you have to look at those patterns, type 2 to type 9. You see it, you need to think about there's another layer, and layer is going on. Conclusion, chronic low-level infections, among other environmental factors, appear to be associated with many human maladies. In patients who continue ill or do not respond to treatments, one ought to consider more than what meets the eyes. Thinking of layers like an onion points towards exploring problems underlying one's systemic illness. Several patterns of SIBO, type 2 through 9, as described in this presentation, may be considered a biological marker for systemic illness. And this is how to restore microbiome, the probiotic exchange method. Okay. Thank you all. Thank you.